Good morning, everyone. How nice that you're here, and this is a day to be celebrated for folks with Parkinson's, the Parkinson community. We welcome you all. And for those that are just coming in, anybody at the door, could please tell folks coming in that there are seats up in the front, and the people that sit on the front will not be tested at the end of the day, so it's safe. Good morning, I'm Nancy Kretz. I'm president of the Parkinson's Association of Northern California, and I am so thrilled to be here. I will talk to you a little bit more about the Parkinson's Association, which we lovingly call PANC, at the lunch break a little bit. But I wanted to take a minute for you to find, or to tell you to, look for our board members. We're wearing these little badges that the AV guy told me I couldn't have it up here because it was too sparkly. But please take time to meet us. And I also want to recognize other volunteers in the room that are facilitators for some of the many support groups. So if you're a facilitator, could you please stand up? And we want to say thank you because there's so many. Oh, see, okay, good. Congratulations to facilitators who really make the world go round for us. It is the grassroots. And I want to recognize you all for coming and attending a program that maybe you had to travel for. You probably certainly had to set your alarm clock for, which is a problem for me. And at a time when we have to recognize there's so much stress in our lives, in the world. Our hearts go out to the folks from the hurricanes and the floods, the shootings, the fires. There is a lot of stress in our world, yet coming together as a community for Parkinson's is healing. And I suspect you're going to feel a lot of positive energy as you go through the day. You've made it here. We're going to celebrate. I want to take a special note to thank Dr. Suketu Kendar, who has been so instrumental in guiding the Parkinson's Association and in building this agenda with us, and certainly bringing together incredible speakers for the day. And you'll get to know him a little bit more if you don't know him already. Also, we're thrilled to have David Leventhal and Dave Iverson, who were part of the Capturing Grace, made the Capturing Grace video that hopefully many of you have seen. And there's more information out in the lobby. I also want to recognize Jan Whitney. She is the woman that kind of has blonde hair, glasses, and you can't really see her because she's moving so fast. And she has been incredible workhorse in putting all the details together for this fabulous day. And of course, we have to thank our sponsors. Parkinson's is a small group, and yet we've had tremendous support from the sponsors, folks that are in the exhibit hall. Please go by and say hi and learn what they have to offer for you, and thank them for part of this day. The breakfast treats and some of the other things were sponsored by our Diamond members, who are Abbott, Adamas, Medtronic, MERS Neurosciences, and UCB, and thank you so much. We have special lunch sponsors as well, AbbVie, US World Meds, and Acadia. These companies really understand why you're here and what you're hoping to learn, and I suspect they will continue to provide that support. A couple logistics. One is volunteers have blue sashes on their badges. Please feel free to ask any of them, if you need anything. I have just found out that there's a family-friendly restroom on the second floor, taking the elevator right out here down to the second floor, and there'll be a sign to guide you to that way. You have on your table index cards and some pens, and you're going to be putting those to use during the expert panel portion of the program, and you'll hear more about that later. I ask that we always be aware of our surroundings and just be safe, as there's multiple exits if needed, and know where they are. So our program here has the agenda, has speakers' bios, it has other information, even some fun stuff in there. But I want to direct your attention to the pack that you have a yellow sheet, and the yellow sheet is an evaluation sheet. And folks, if you want to pull this out early in the day and then just take notes, because we want your feedback so badly so we can make next year's program even better. So, let's see if I can do this right. What is it? Okay, I'll tell you what it is. When we heard that the date for our getting this venue here was October 21st, we were reminded that, oh, that's an important date. That date is from the movie Back to the Future. And in part, it inspired our concept of going into the future, and that's the theme of our program today. Future can always change in a heartbeat. This is one of the most famous American philosophers I've ever heard. The future ain't what it used to be. And we certainly know that's true, particularly with a chronic condition that changes over time. Your future may change too. What our hope is for today is to really get you inspired and to understand that you build your future. You have the ability to do that, and you can do that. And today, the talks, the information, are tools that are geared to help you understand how better to build your future and feel confident about it. So with that, get me stopping to talk. There's our wonderful sponsors. I would like to introduce our first speaker, who is Dr. Suketu Kandar. He is a neurologist, a movement disorder specialist, and is the medical director of the Comprehensive Movement Program at Kaiser Permanente in Northern California. This man is dedicated to the Parkinson world, and it is a real treat to have him talk with you today. And he'll have a couple little surprises along the way, too. So for the AV people, I'm done for now. We'll get Dr. Kandar set up. Doctor?
Thank you, Nancy. Thank you for those kind words, and thank you all for allowing me to speak to you here today. Wow, this is a big room, a lot of people. Quite excited to see that this room is full. You guys should really see what I'm seeing right now, although I was told by management that I couldn't bring you all up here, so you have to take my word for it. And I'm hoping that this generates a lot of buzz, and I'm kind of half hoping that our President Trump actually tweets about it tonight. We'll see what happens. Now, that being said and done, like Nancy said, I'm a neurologist at Kaiser Permanente here in Sacramento, and I'm excited to talk to you a little bit about why this year is so important. This year marks the 200th year anniversary of Dr. James Parkinson writing his manuscript, publishing his manuscript called The Shaking Palsy. So we'll talk about that in just a second. Get my first slide going. There we go. Okay. So a lesson in history. Why are we reviewing this history? Like I mentioned, Dr. Parkinson published that manuscript in The Lancet 200 years ago to the day, actually called The Shaking Palsy. If you guys take a look in your blue tote bag at the time that you registered, you all got a copy of the original manuscript, which is quite exciting if you think about it. This was written 200 years ago and still actually makes a lot of sense here today. And we're going to talk a little bit about the history. Now, why is this important? Because I think that if we're going to look into the future, we have to understand where we've been. And so I thought if I take you through a little bit of that history, you'll understand some of the evolution that's happened over the years. So 200 years ago, let's think back. It's kind of hard for us to remember that time, right? But who was president at that time? Anybody? It was James Monroe, our 5th president, the last founding father to actually become president. James Monroe started his presidency in 1817, right after James Madison. Back to the slide deck, please. That was the year that the New York Stock Exchange actually was founded. First year that an African American graduated from college in this country. And it also was, during that time, Beethoven was the most famous composer in Europe, probably the whole world for that matter. It's a long time ago. So who was James Parkinson? Well, where it all began was in England. He was an English physician in Hoxton, England, okay, not too far north of London. So help we all orient ourselves, get a little bit of geography. And this is a picture of Dr. Parkinson. Now, it's a little bit of a grainy photograph. This I pulled from the internet. And then I started thinking for a little while. I thought, wait a second, this gentleman was born in 1755. How many other pictures are there from that era? Right? There's no pictures of George Washington. There's no pictures of James Monroe. There's no pictures of Beethoven. They're all portraits. So how is it that we're able to get a grainy photograph of Dr. James Parkinson? So I thought about the timeline a little bit, did a little investigation. Dr. Parkinson actually passed away in 1824. The world's first photograph was actually from 1825, sorry. So how is it that there's a living photograph of Dr. Parkinson? So I investigated a little bit further, and I realized that James Parkinson, that name is actually quite common in England. So this Dr. Parkinson is actually a dentist who lived 70 years later. Case in point, don't believe everything you read on the internet. So who was Dr. Parkinson? He was a general medical practitioner, not a neurologist. His father was an apothecary and surgeon. At that time, you sort of did what your father did, right? It was a trade business. He studied at London Hospital. He was a prolific author. He actually did a lot more than just medicine. He was a remarkable man. So he did a lot of government reform, actually worked in public health. He wrote an essay on children's safety. What types of games and what types of activities should children not do because it might put them at risk of injury? I want my kids to read that. And he also was a geologist. Amazingly random, but he actually was one of the founding fathers of the London Geology Society. And then, oh, by the way, he also wrote articles on gout and appendicitis. In fact, he was the first person in the world to write an article on appendicitis that ultimately led to someone's demise, basically outlining how important that was. So in The Shaking Palsy, and you'll be able to thumb through that at some point in the future, he wrote, "Involuntary tremulous motion with lessened power, in parts, not in action, and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace, the senses and intellects being uninjured." Very descriptive. He made this description based on 6 individuals. All 6 case presentations are in the Shaking Palsy manuscript, 2 of which he saw in his own clinic, 2 of which he actually saw as innocent bystanders, and 2 of which he met in a public park on his way home. And over the years, he was able to identify various features that were common threads between these 6 individuals, and hence came up with the idea that maybe this is one syndrome, maybe this is one condition. The common things between all of them was that they had tremor. Common things between all of them was that they had a stooped posture. Common amongst all of them was that they were not as strong as they would like to be. And so he made all these observations and basically put it together in that manuscript. But he was wrong about a few things. As brilliant of an observer as he was wrong about a few things. We'll get to that in a second. So what's his legacy? Nobody remembers now, at least in our country, that he was a geologist, that he did all these other things outside of Parkinson's because his name is sort of ingrained into medical culture as the person who helped to discover Parkinson's disease. So Shaking Palsy, and that plaque, that blue plaque, sits actually where his office once stood in London. You can go there today and you'll see that blue plaque there. That basically outlines that he's a physician and in larger print, a geologist. So what is he known for again? He's known for making those brilliant observations, but he actually did not observe bradykinesia or rigidity. If you look throughout that Shaking Palsy manuscript, there's not much mention of either of those 2 things. In fact, he thought that it was a motor weakness. That's why he called it the shaking palsy. Palsy, by definition, is basically a motor weakness. And so he called it paralysis agitans. You're weak and you're agitated in the sense that you're having a lot of tremor and implying weakness. He was, however, mindful of the postural and the gait changes. But who was it that really helped to shape what Parkinson's is as we understand it today? And that's Dr. Jean-Martin Charcot. Dr. Charcot is the father of modern neurology. He's a French neurologist, actually. Interestingly enough, he worked at a Salpêtrière hospital in Paris. And he collected around him a lot of other brilliant minds, Sigmund Freud being one of them. He and Dr. Freud would get together on a monthly basis and have conversation about neurology and psychiatry. I would love to have been a fly on that wall. And in 1872, years after Dr. Parkinson passed away and years after the Shaking Palsy manuscript, he further defined what Parkinson's disease was. And he attributed that there's more than just shaking and there's more than just postural changes. Let's add these ideas and components of bradykinesia and rigidity. And then he went ahead and honored Dr. Parkinson's by coining the term Parkinson's disease. It's kind of hard for you to self-honor, saying that Dr. Parkinson's didn't call it Parkinson's, but it was Dr. Charcot that basically gave him the due credit. He also went further and defined that there's two different subtypes of Parkinson's. Those people who are very stiff and slow, call them the akinetic rigid syndrome patients. And those people who have more in the way of tremor, but a little bit better mobility, tremor predominant patients. He was the first person to identify that there's multiple subtypes of Parkinson's. Make no mistake, Parkinson's isn't one condition, it's a spectrum disorder. So therefore, there are some people who may express the condition differently than others. But if you were to parse out two major subtypes, it still goes back to what Dr. Charcot mentioned really back in 1872. So what did he go on to say? In spite of tremor, a patient is still able to do most things, but he performs them with remarkable slowness. And I find this sentence quite interesting. See, a lot of patients who develop Parkinson's, a lot of their family members notice that they can't do what they used to before. And Dr. Charcot is telling you here that's not true. You can do what you were able to do before, maybe a little bit slower, but you are able to do it. So it's an interesting point that I thought that he made. So what were some of the early medical treatments that people used at that time? So Dr. Parkinson actually advocated bloodletting, basically venipuncture. Make a little incision in the neck, let the blood come out a little bit. That was back in the time when they felt that there were a lot of demons circulating in our circulatory system. I'm so happy that we're not doing this here today, okay? Then they used to use things like belladonna. These are now anticholinergic type medications or type herbal supplements. Sometimes we use this here today, okay? Very similar to things like Benadryl in order to help with tremor. Then people used vibration therapy, maybe to somehow mask the tremor. People used these suspension apparatuses that might potentially stretch the spinal cord because they thought that maybe at that time the seat of the problem was in the spinal cord, not necessarily in the brain. They used to do a lot of electrical stimulation. Now, I'm not talking about brain stimulation, we're talking about bodily stimulation. So they used to basically zap you with electricity. And they used a whole array of medications or supplements such as arsenic, morphine, hemlock, cannabis, I know a lot of you guys are raising your eyebrows right now, and opium. So this is actually a picture of Dr. Charcot's vibration chair. And next to it, I think it's kind of fancy actually with the little ruffles at the bottom. I thought that was a nice touch. And then the other apparatus actually is a torture rack, but very similar to Dr. Charcot's spinal cord stretching device. I certainly do not have either of these items in my office right now. So we're actually going to fast forward a little bit and talk about Dr. Frederick Lewy. So we all know a little bit about Lewy bodies and Lewy body dementia. And sometimes a lot of my patients and their family members worry that, well, does my family member have Lewy body disease? Well, let's talk about what is Lewy body. So Dr. Frederick Lewy is a German neurologist back around the turn of the century. So he was born in the late 1800s and lived through the early 1900s. And then actually emigrated to the States. He worked in Dr. Alzheimer's lab. So Dr. Lewy and Dr. Alzheimer's were contemporary, which is pretty cool if you think about it. And what he was mainly a pathologist. And so he looked at autopsied brains of those people with Parkinson's disease, looked under a microscope. Sometimes when you take a piece of brain tissue and you fix it to a microscope slide, you have to use a particular stain, something called an H&E stain. And he noticed that a lot of Parkinson patients had these large inclusion bodies, storage units that were sort of ingrained within the cell that were not supposed to be there. He called them Lewy bodies. And what we found out later is that this is an accumulation of abnormal protein called alpha-synuclein, which is really the pathological hallmark of Parkinson's disease. So he was the first person to identify that these are abnormal in those people with Parkinson's, and it's common amongst all Parkinson's syndromes. Now, what distinguishes Parkinson's disease from Lewy body disease is that in Parkinson's, you only find this in select areas of the brain. In Lewy body disease, right from the get-go, you find it everywhere. And so there is a difference in the type of symptoms that patients tend to experience. In Parkinson's, you start with some preclinical non-motor signs, go on to develop some motor symptoms, and over time, you may develop some cognitive impairment. With Lewy body dementia, you start with the cognitive impairment. The motor symptoms accompany it around the same time. It's a very different course, a very different condition. Now, we're going to fast forward again. 1967. Two things happened that year. Summer of Love and the discovery of levodopa, and that's the chemical composure of levodopa. You decide which one was most important that year. And so what came of that? Levodopa was revolutionary. People awoke from being in a very akinetic, rigid state, because all of a sudden, with all of us know that the pathology in Parkinson's is there's not enough production of dopamine. So the treatment is going to be to somehow supplement dopamine. So by giving these folks dopamine, all of a sudden they started having more mobility. They awoke from a state that they were in before. So the consequences of that therapy is what? We started developing all these medications that help to deliver dopamine into the brain, some of which are just synthetic forms of precursors of dopamine that then get converted into dopamine, and others that are mimicking dopamine and kind of act on the dopamine receptor. And this basically evolved into medications like dopamine agonists, such as pramipexole and ropinirole and rotigotine, or other various subtypes of levodopa we now lovingly refer to as Sinemet. By the way, do you guys know why it's called Sinemet? Okay, so there's sometimes always a little story behind the name. So when levodopa first came out back in 1967, it was only given as levodopa. It was not the combo therapy of carbidopa and levodopa. And it caused significant nausea in people. Everybody with levodopa alone got nauseated, threw up, couldn't really tolerate the medication. They don't really show that to you in the movie The Awakenings, the one with Robert De Niro and Robin Williams, but that did happen at that time. And by the addition of carbidopa, it helped to protect the levodopa from being broken down peripherally before it got a chance to get into the brain, thereby reducing the emesis, reducing the nausea. So sin in Latin means without, and emet is short for emesis. So sin emet, without emesis. So the evolution actually went on to different delivery methods when it came to how we were going to give it orally, are we going to try to give it in other forms? And still, we rely heavily on the oral medications. If you think about it, it's actually quite unnatural. Dopamine, for the most part, is produced in the brain, used in the brain, broken down and recirculated in the brain. Yet we're taking something orally in a very unnatural fashion, right? You're not making dopamine at 8 a.m. and 11 a.m. and 3 p.m., these various times that your doctor might have told you to take your meds. Your brain's making it continually. And yet we're having to supplement it in a very unnatural way. So this is what people have always thought. Let's try to recreate dopamine production in a more natural fashion. And then there is, what else has happened because of this? We've realized that there are actually various subtypes of Parkinson's, more so than what Dr. Charcot first described. And we realize this because there's some people who are more prone to dyskinesia, some people less prone to dyskinesia. Dyskinesia was even, we didn't know what it was until after the discovery of levodopa. And so we understood that some people are more prone to these types of things, and we've basically realized a little bit more about the evolution of the condition. And that led to this, the discovery of the motor pathway. You guys will get a test on this later today, okay? So this is the circuitry that's involved in Parkinson pathology. Now, this is the normal circuitry, but if broken down in certain areas, it leads to the clinical features of Parkinson's disease, the stiffness, the slowness, the tremor. And the major neurochemical that's responsible for making this circuitry happen is dopamine, which is why we actually supplement dopamine. Now, who was it that actually first discovered that this was the main circuit issue in Parkinson's? It was Dr. Malin DeLong. Now, these are not the same people. I know they look exactly the same. They got the same tie even. They're not the same people. Dr. Malin DeLong is a well-known professor emeritus out of Emory Medical Center in Atlanta, Georgia. And Dr. DeLong has dedicated his whole life, 40 years of practice, to that circuitry. So he's the foremost authority in the whole world on dopamine basal ganglial circuitry. But that led to Dr. Benabid, who's a French neurosurgeon out of Grenoble, France, to take some of that information and recognize that maybe stimulating those areas in the brain actually can help to produce symptomatic relief, thereby balancing out giving the medications. So Dr. Benabid was the first to discover that deep brain stimulation could be a possible treatment for Parkinson's disease. He was the first to actually do an implant. So the surgical treatments are a little bit more recent. Not that recent, but relatively speaking recent if you're looking at 200 years, right? So historically, back in the 60s and 70s, when people started recognizing that the basal ganglia was involved, people used to actually do a craniotomy. They'd actually take a little piece of skull out, they'd go into the brain and cauterize the area that they were thought was responsible. And you can imagine back at that time, without good neuroimaging, they may hit target, they may be a little bit off from target. And therefore, people may potentially get side effects afterwards. But hundreds, thousands of these cases were done back in the 60s and 70s. Around that time, levodopa came out, revolutionized how we do Parkinson care, and surgery fell out of favor. But when motor fluctuations and dyskinesia started to develop in patients, surgery came back into the light again. And deep brain stimulation was first done in the mid-1980s. It wasn't until 1997 that it came to this country and was FDA approved for genetic tremor disorders. 2002, FDA approved for Parkinson's disease in 2 different targets of the brain, the globus pallidus interna and the subthalamic nucleus. But deep brain stimulation is also not going to be the end-all for all treatment in Parkinson's disease. It also has led to an evolution of other types of surgical treatments. That includes stereotactic radiosurgery, gamma knife surgery, cyber knife surgery, or more recently, MR-guided focused ultrasound, which right now is only FDA approved for essential tremor, not for Parkinson's, but we give it time and it may potentially be approved for that as well. So as you discover one thing, it opens the door for many other things. As you open those doors, it opens the doors for a few more things, and you start understanding the condition a little bit more. It's not just about supplementing dopamine. It's not just about trying to balance that neurochemistry. It's about trying to give patients the whole, the holistic approach. So for me, it's just because we start medication doesn't mean we're done with the treatment. So what am I trying to get at? The tide is shifting. And what do I mean by that? And I actually took this from Eli Pollard, who's actually the executive director of the World Parkinson Coalition. In the last 10 years, there's been a change, and I've seen it since I've been working for almost 15 years in this field. I've seen a change in how things are done when it comes to Parkinson care. It's not step by step as much as it is leap by leap. So, and what has really changed? Up until about a decade ago, right? What would happen is that all research was really being done by large volume centers, but only select centers across the world, select centers in this country. And it was really up to the physician, up to the provider to identify patients. Patients themselves didn't necessarily come forward to advocate for themselves, to want to be participant in research. And so patients have become empowered. You can credit the internet a little bit for that. You can credit just the fact that there's so many of these advocacy groups around, celebrity voices, national advocacy programs, the Parkinson Association of Northern California, the National Parkinson Foundation, which is actually now the Parkinson Foundation, because they merged with the Parkinson Disease Foundation. All these programs are now at our fingertips, and all this information is at our fingertips. And it's allowed a lot of empowerment for patients, which is wonderful, because patients are coming forward and asking, I want to be part of this. I want part of a broader community. I want to actually participate in research. And it has lended to a lot more in the way of understanding of our condition, of this condition. Third thing, actually, so one is the fact that research and participant care has changed. One is that there is a lot more connectivity between caregiving, provider caregiving, and patients. And the third is the use and the understanding of interdisciplinary or multidisciplinary care. Right? So when I first started working at Kaiser, we realized that the point person is the neurologist, and that's it. And sometimes you see them, sometimes you don't. It was not uncommon at that time for the neurologist to tell their patient, yeah, why don't you just see me when you think it's important to see me? They're, putting a lot of onus on the patient, but at the same time, the patient didn't have enough information to understand when it was time to come back again. And not recruiting anybody else to be part of that care delivery. That tide is shifting. And patients now are embracing that self-care, that empowerment. And exercise, physical therapy have actually become a cornerstone of the treatment. So for me, exercise is medicine. For my therapist in Kaiser, exercise is medicine. And it makes a lot of sense if you think about it. It's a mobility disorder, right? You want to gas your car, it's no fun unless you actually drive it. And this is an analogy I give my patients a lot. If you want to give yourself dopamine, don't expect that by sitting on the couch, all of a sudden your mobility is better. By getting up, moving about, doing things, being aggressive about the exercise, taking that ownership, you're going to do a lot better. And a lot of studies have shown that's the case. The last thing I want to tell you is that I want to be a little bit provocative in saying that let's do away with the word patient. I don't like that word, right? First of all, it embodies something that's very passive in nature. Patient, right? That be patient. But the word itself actually is derived from Latin. It means one who suffers. That's what it means, right? I don't like that term at all. And this is why I'm advocating we change it to persons with Parkinson's disease. And therefore, this is a condition you have, but you don't allow that condition to become and define who you are. Thank you. So what does multidisciplinary care look like? And who are the people that you might want to recruit on your team? Mind you, I'm using the word your team, not the neurologist team. So obviously the neurologist, right? Primary care services. I think it's important for primary care medicine to understand what Parkinson's disease. They don't need to understand every aspect of it. They're not neurologists, but they should be familiar with it. Therapy services, PT, speech therapy, occupational therapy. Mental health services if necessary. Neurosurgery if necessary. Urology. And social services. These are all the people that you may want to recruit at some point. You don't need to recruit them initially at the time of diagnosis, but over the course of your condition, whether you be at Kaiser Permanente or any of the other institutions that are here locally, by all means, if you think that any of these providers can lend a hand into your quality, recruit them. And I think that actually lends to my philosophy, is that I find that a appropriate and a practical treatment approach needs three things. Number one, right diagnosis with the right medications. Number two, aggressive neuro-PT. I'm not talking about, I was cycling on my recumbent bicycle and I'm doing about 30 RPMs. No, I'm talking about 60 to 70 RPMs. I'm talking about going out and doing rock steady. And I got to give a shout out to the rock steady folks for that brilliant presentation this morning. Thank you. I'm talking about going out and doing aquatic therapy, LSVT, big, power, boot camp, Tai Chi, yoga. All these things have been studied and looked at in Parkinson's. Take your pick. Dance therapy, for example, okay, which you guys will hear a lot more about later. And then the third thing, and I find this to be the most important piece, patient empowerment. Take charge of your condition. It's your condition to have. As a provider, my job and my responsibility is to outline it for you, to show you the way, to define it for you, to provide you the roadmap. Oftentimes, Parkinson's is kind of like Disneyland, okay? Now, we all love Disneyland, or maybe you have a different perception of Disneyland. But when you walk into Disneyland, it is amazingly overwhelming, right? You have no idea where you should go and how you should spend your day. But that roadmap that's given to you, right, that little map that tells you exactly where you should go and where everything is, helps to define some of that for you. I find that the providers are the roadmap. but it's your journey to have in Disneyland or with Parkinson's disease. And so if you don't take charge of that, you're just going to be walking around Disneyland quite idle. And so take charge with how you think you can better improve your quality. And I have to give you all credit because you all wouldn't be here if you weren't thinking along those lines. And I also want, for those of you with Parkinson's sitting in the audience today, I want you to actually, during the break, thank the person who brought you here. Actually, there's a lot of that's put on their shoulders, and they're here with you. They're the ones who brought you here. They're the ones that have enabled you to be empowered, and they're in this journey with you too. So please thank the person that brought you here too as well. So with that, I'm going to end with something that Michael J. Fox said. I don't have any choice whether or not I have Parkinson's. But surrounding that non-choice is a million other choices that I can make. And that's me with Dave and David. So thank you all for actually having me here today and speak to you today. Hopefully it's giving you a little bit of insight on where we've been, and the rest of today will hopefully be where are we going. Thank you.
Christine Shade, where are you? Christine, there she comes. We have an invigorate break to get things going and get things going, get you going, get us all going and moving. And at that point, this will be about 5 minutes, and then we'll have the expert panelists up here and do the very exciting part of our talk in that regard. So Christine, how are you going to shake us up? Christine is a neurophysical therapist, and she has her practice at Kaiser with primarily Parkinson's folks. There we go. Just a tiny table issue. Are you turned on, Christine?
I don't know. Am I?
Oh, that
Can you hear
didn't
me?
sound right.
Yes? Perfect. Okay, so I'd like everyone to sit up nice and tall in their seats. Let's try and scoot your chairs so everyone can face me and see me, please. And then you're going to want some room for your legs, if possible. Perfect. So hopefully we're all sitting towards the edge of our seats, and we're sitting up tall. Let's start with just rolling our shoulders back real quick. Nice and big. We could even smile and act like we like it, right? Good, good. Now I want us to start marching our legs, but the trick is with the legs, I want to see how fast you can go. And you can't lean back into your seat. So you have to stay sitting up tall, march those feet, and try to run. And if you can even move your arms. If your feet get caught up with that coordination, just stop and restart. But I want everyone to go as fast and as hard as you can for 30 seconds. Ready, set, go. Go, 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 go. And we're still sitting up tall, right? It's kind of dark, so I can't see if you're smiling, but I hope you are. Go, 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 go. We're almost done, almost done. 5 seconds. And go. We are done. Good. Okay, now we're going to stay in that same position, and I want you to take your hands and hold on to the sides of your chair. We're going to lean back a little bit, and we're going to put our legs straight out in front of us. Try not to kick your neighbor. And we're going to kick our legs up and down. We should feel this in our stomach muscles. If you're not feeling it in your stomach, then scoot your bottom forward more and lean back more. Okay, we're going to go 30 seconds, and we're going to go fast. Ready, set, go, 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 go. We also want to make sure we're breathing, right? No holding your breath. Go, 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 go. Keep it going, keep it going. We've got 10 more seconds. Those of you who take my group classes will appreciate that I actually have a timekeeper for this now. 5 seconds. And we're good. That's a good one, right? Everyone kind of breathing a little hard. We're going to get back in that same position, and this time we're going to crisscross our legs. So I call these scissors, but in and out. Okay, we're going to go 30 seconds and go. Go, 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 go. This is the tough one. And we could have a smile on our face to work our face muscles. And we're breathing, right? Yeah. And we're good. Woo, that was a good one, right? Okay, now I want us to practice standing up and sitting down. So make sure you have room, right, to stand all the way up and sit down. But the trick is, so many of us with Parkinson's, when you stand up, you tend to lean back, right? So that weight is all in your heels and you're tipping backwards. So we need to practice getting our nose over our toes. And make sure you have enough room, right? And for balance, you can have a walker in front of you or a chair if you need to hold on to something. So let's practice. We're going to get our nose over our toes, and we're going to stand up nice and tall. Good. And then we're going to sit down. When we sit down, be careful on these chairs, right? We need to sit down nice and slow. Okay, we're going to do it again. So stand up. Good. Next time when we stand up, let's practice. Let's put our hands back and reach back behind us to really open up our chests. Good. Now we're going to sit down. Okay, so this time when we stand up tall, we're going to put our arms back. Ready? Stand up, arms back. Nice. And sit down. Okay, we're going to do it 10 times, but when we come up, I want us to count. So we're going to count out our 10. So it should get really loud in here, right? Okay, ready? I should not be the only one counting. And go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, let's stay standing up. Nice. Good. Very good. When we're standing here, let's try, again, don't hit your partner. Let's open up our arms really wide. And I want your fingers nice and wide too. If you can't stand up, that's fine. You can stay sitting, but remember my rule. You can't sit against your backrest. So try to scoot forward in your chair if you're sitting. Perfect. So now let's all try to coordinate nicely. We're going to use your right arm, my left, but your right. And you're going to twist over and touch that hand. So you're going to clap your other hand. Good. Now let's open up really big to the middle. Good. And twist towards the other side. Good. And open. And twist. And open. And twist. And open. And twist. And open. And twist. And open. Twist. Open. Twist one more time, open, twist, and open, twist. Very nice. Okay, nope, don't sit down yet. Let's try one more. I want to see if we can try and walk in place. Nice. So if your balance allows, we'll try to get our knees up more. Also notice I'm swinging my arms. So we want to move our arms and our legs. And our chests are up nice and tall, our heads are up. And we're breathing. Very nice. You can even try having a surprise face on, right? While walking, so we use our face muscles. Perfect, and go ahead and stop. Good, do we have more? We're good? Okay, now it is break time.
All right, why don't we begin? So again, my name is Suketu Kandar. I'm a movement disorder neurologist in Kaiser, Sacramento. I have nothing to disclose, neither do any of the members of our panel here today. Although I must say, the one thing I do have to disclose is that my wife has always told me that I have two loves in my life, her and Parkinson's, and she's never quite sure which one is first. Now, that being said, I have the pleasure of introducing our panel here. This panel was something that was forged about 4 years ago in an attempt to be able to answer everyone's questions. And so on your table, you will have, and Nancy had mentioned this previously, you'll have note cards. As this first hour goes through, if you have burning questions that you want to ask of the panel, please jot them down on that postcard. And we will collect the postcards at the end of the first hour, and then of course we have a few other events and lunch break, and we will sift through those postcards for the more important questions that we can then, when we reconvene this panel in the afternoon, we'll pitch back to the panel. So this way a lot of people get their questions answered, and as you might appreciate, a lot of questions sometimes are similar and redundant. So I want to make sure that we try to get to everybody as best as possible, but for this first hour, after I do the introductions, I have populated a few questions that I'll be posing to the panel. Now, a couple things about the panel. Why do we do this? Number one, this is a collection of a lot of experts from our institutions here locally in Sacramento. So Kaiser, Sutter, Mercy. UC Davis is actually going to be giving some talks a little bit later this afternoon. But the beauty of and the value of the panel is to show a couple of things. Number one, sometimes the answer isn't always easy. And I really want to pitch difficult questions to the panel so that the panel can talk amongst themselves. This is also not scripted. So I really want the experts of the panel to be able to, on the cuff, be able to explain their thought process and how, again, sometimes it's not easy answers, sometimes it is, and sometimes the answers may be different from one provider to the next. So we'll start with Aaron Vestal. Aaron, raise your hand. Aaron is a neurophysical therapist in Roseville, Kaiser. Aaron is someone who walks the walk and talks the talk. So Aaron is one of those people who wakes up early in the morning and goes for a jog before she actually starts her day. She's someone who, about a year ago, I think it was a year back, that she sent me a picture of her doing rapids in the Colorado River. I'd never done rapids before, and I felt compelled to actually send something back to her. So I showed a picture of my family at the rapids at Disneyland. Not the same thing, but still, I needed to one-up. Dr. Thacker is a movement disorder specialist out of Sutter, Sacramento. And Dr. Thacker did his training out of BNI in Phoenix, Arizona, and has a wonderful movement disorder practice there. He also wanted me to let everybody know that he's a huge Taylor Swift fan. And he's the incoming president for the local fan club, but only the Sacramento chapter. He's hoping for higher aspirations later.
Oh, that's great.
Kimberly Lani is a neuropsychologist from Kaiser Roseville. Now, some of you might question, what is a neuropsychologist? So a neuropsychologist really has a lot of responsibility. One is they can actually do metric testing to help understand what is your neuropsychological and your neurocognitive profile. So they basically know you better than you know yourself. But her job is to help understand where those things, where your cognition lies and how, sometimes those things can limit you. Or not. Dr. Hadi. Dr. Hadi is a movement disorder specialist out of Mercy Dignity here in Sacramento. Did his training in Loma Linda Medical Center, and also a wonderful movement disorder program and practice out there. Dr. Hadi also, you can find him on the upcoming So You Think You Can Dance season. They apparently got wind that he is a movement expert and didn't quite understand that he doesn't dance. Well, I don't, do you dance? And Renee Gardner. Renee Gardner is a speech therapist out of Sutter, but also works at Sac State, I believe. And Renee, a speech therapist, is not just what you think. A speech therapist actually has a huge and broad range of the things that they do. So it's not just LSVT, or it's not just Speak Now, but speech therapists also do swallowing therapy for some people who may have some difficulty with that. And a speech therapist also does cognitive retraining and cognitive rehab. Sometimes we don't often leverage them for that, and we often think that, okay, well, they're just going to do the LSVT, or they're just going to be able to help me with my softer pitch in the voice. But there's quite a bit more they can do. So hopefully I've done that justice.
Yes.
Okay. So, rules to the panel. This is not a fight, okay? We're just here to discuss and have dialogue, open dialogue about some of the things that tend to plague a lot of our patients. So I'm going to start with a question that actually was asked during that last break. How does one treat apathy? Apathy is something, so if you don't know what apathy is lack of motivation. A lot of Parkinson patients tend to have that. This is the time where I bring a patient into the office, they come in with a loved one, I look at the patient, I ask them, so have you been exercising? They're like, oh, yeah, sure, I've been exercising. And then you got the partner that's sitting there going, nope, not at all, I can't. I can keep nagging them and keep nagging them. And, you know, a lot of that is really kind of built up into this term apathy. How do we counsel patients and their loved ones on apathy? Who wants to take that? Are these not all at once? Yeah, mics are on.
So apathy, can be actually often difficult because it's, something separate than what you think of depression, where you're just feeling down or not happy. It's more of a motivational thing. And so I think, number one, interaction, trying to socially and physically interact. Exercise is one of the best medicines for everything. And then we do also try antidepressants, and they can help stimulate, but sometimes we'll actually have to give stimulants like Provigil. And so it's, I think, starts with trying to, push the patient to interact with others and exercise. I don't know if our neuropsychologist has any other recommendations that she...
Yeah, I think one of the first things I would screen for would be depression, because lack of enjoyment and interest in activities is one of the primary symptoms of that condition. So I think if there is significant depression, it can definitely limit one's enjoyment in activities and therefore desire and motivation to engage in them. But I also think that adhering to a structured schedule after you've tried some of the medications as well can be helpful, and exercising regularly and getting out there and doing it even when you don't feel like it, it can be rewarding and help with some of that.
Renee, Aaron, you guys have anything to add?
Well, I'm a strong proponent of humor, and so I ask a lot of my patients when they're feeling low or feeling down or apathetic to watch something that might bring forth some laughter, whether for some individuals it might be Archie, for some people it might be Red Skelton, some people love Lucy. It depends upon what tickles your funny bone. But I do encourage a lot of my patients to think of ways that they can facilitate laughter for themselves and for their family and or friends. And so I have a riddle. Here's an example of something I ask patients to practice. Also exercises for their lips. Question: who is bigger, Mr. Bigger or Mr. Bigger's baby? Note how I'm over-articulating, right? Answer: Mr. Bigger's baby, because he is a little bigger.
I think we've heard now twice, right, at the word exercise from both of our experts on the panel. So I want to talk about the benefit, really, when we talk about apathy, of exercise in groups. So the fun thing is, and you guys saw Christine earlier today, that whether it's a physical therapist, our amazing Rocksteady coaches, dance instructors, yoga teachers, finding someone that can push you or your loved one in the right way. We know we're mostly by nature competitive as humans, and in these class dynamics, you find some of these folks that have a hard time being motivated, suddenly they want to keep up with the person exercising next to them, and it's really exciting for us to see that. So finding a group to work out in can sometimes help with that motivation that you might lack. You know your buddies are going to call you if you don't show up to class, plus any of the panelists here are going to ask you at your next appointment, how's your exercise going? And those groups can be really, really helpful to keep that motivation going.
All right, thank you all. We're going to start with our next question. So a lot of times we get patients in the office, they've been recently diagnosed, or maybe it's been a little while since they've diagnosed. But a question I often is posed to my clinic is, when is the best time to start medical therapy, prescription-based therapy? So I'll start with you, Dr. Hadi.
So it's, it's something that I usually talk to the patient, describe their symptoms, describe the, state that they're in, what stage of the condition that they're in. It's right now, obviously we know there is no curative treatment for Parkinson's. And all the medicines that we have so far, there's no evidence, strong evidence that shows that they alter the course of the condition. But there's some medicines we have that we think may have a role there. So it depends. People who basically start everybody on medications when they come in, but it depends on their nature of employment, their functionality, and that kind of helps me guide along with the patient to see what kind of medicines they need to be started at and basically how much medicine they need. So it's not as simple as, okay, everybody comes in, gets started on dopaminergic medication. It depends on a lot of factors, age and employment and all that stuff.
Dr. Thacker?
Yes, I totally agree. It's quite variable on each patient. In general, as far as starting, drugs like levodopa or Sinemet, that's kind of the major decision people make, because of the potential complications in the future. And so when we're upping the therapy to something like that, we generally, when your symptoms are, interfering with daily activities, they prevent you from exercising, things that we know that could potentially slow progression, that's when we're wanting to start a drug like levodopa to definitely, hopefully, improve symptoms. So it's quite variable, but as far as starting everyone with the same kind of cocktail, it doesn't really work that way. Every patient's different.
Thank you. So one of the more challenging symptoms in Parkinson's tends to be when patients start to develop some postural changes. By that I mean a little bit of a head drop and that cowering posture that sort of allows them to be bent forward. So when that starts happening, I feel like at times it might mark the beginning of another stage in their Parkinson's. How do we address that? Erin?
I can say from the exercise perspective, we've got a couple considerations there, because one of our duties, if you will, as physical therapists, we do have our neuro PTs, but we have orthopedic PTs. So there might be back pain associated, neck pain associated, might even be a dystonia, a cervical dystonia. So as therapists, we're trying to educate other therapists to notice these types of things, which gets people started on an exercise regimen potentially earlier. As our neuro PTs, if we're encountering this in patients that we know have Parkinson's disease, we've got a multitude of exercise that we're working on to try to, as you heard earlier from Christine, open up the chest. And we put people in different positions. We might have them stand against the wall for some input to understand what standing upright actually feels like, because unfortunately this stooped posture becomes a normal. So we use the wall, we may use the floor and have people lying flat on the floor, but there's a host of exercises that we try to initiate early, and hopefully before that even happens.
And sometimes these same patients are asking and emailing about, well, now my symptoms have gotten much worse, I need to up the dose of medications. But they still have that's the postural stability and the postural changes that they're most concerned about. Dr. Hadi, Dr. Thacker, either one, what do you counsel them on how medications affect that?
So, I obviously want to assess them and make sure that they're not under-medicated at that point. Is that something of, stiffness or, other motor symptoms that are contributing to that? And once I've determined, okay, can they benefit? I usually give them a trial of some additional medicine just to see if they will respond to it, if it improves the posture. But not just that, it's never one thing in Parkinson's. You have to do physical or postural exercises plus medication. So it's a combination of things most times.
Dr. Thacker?
So with the postural instability, sometimes that goes along with other changes, changes in cognition, with mild cognitive impairment, even dementia as we advance. And so those are other things you have to look at when the balance is kind of declining, because it, like Dr. Kandar said, it could be another stage. So we always screen them, and some of the Alzheimer medications have been shown to help gate in these cases. So we are occasionally trying these sort of medications. But I agree with Hadi that we need to, evaluate them. Is there a dystonia? Potentially, more Cinemet is needed. So every patient needs to be looked at.
And then Dr. Lani, would you agree that when patients start having a little bit more of those postural changes, you're seeing a decline in their cognitive function?
Yeah, and also socially. Social factors start to come into play and people become more withdrawn because it's harder to communicate and they're misperceived in social interaction, which also adds another layer and can further hasten the decline in cognition.
So, you always do feedback with patients after they've done a neurocognitive testing with you. What do you counsel them when it comes to social hindrance?
When it comes to
Social hindrance, they're basically withdrawing from society.
Yeah, so it's really important to get out there and stay engaged in social relationships because social interaction is one of the biggest factors in the literature to help preserve cognition in aging. Because when you're getting together with a friend for coffee, catching up on life, you're practicing, working memory and staying mentally engaged in attention and concentration, and you're using your brain as a muscle in those interactions. And you're also getting social support, which is a protective factor. Sometimes it's important to really change how you're talking with folks because, and to educate the people around you as well, because as your symptoms progress and you're less able to use facial expressions and nonverbal communication, you really want to be watching how you use overt communication and language and speaking directly rather than indirectly with what you want to say and what you want to communicate, and asking for that feedback from others as well.
Renee, anything to add to that?
So I would echo that in that I share with my patients that the literature and the research shows that those individuals who stay connected and who have a rich social network, that they perform better cognitively. They also tend to live longer and are happier. So I emphasize that, and I also early on when they start to see some of these changes, I emphasize the importance of safety. And so often with the family and with the patient, we develop a very personal safety checklist because sometimes there is variability with cognitive abilities. As one's more tired, we tend to be less cognitively acute. So we emphasize the importance of creating this personal safety checklist, usually in large font, and we type that and print that and then ask the patient and the family members to really honor that and to make that a part of an external cue to help with the cognition and to optimize safety.
I have some patients, Renee, that, I tell them about the need for social engagement, the need for doing, how that's going to improve their cognition. And then sometimes the response is that, well, I'm doing Lumosity and I'm also doing solitaire on the computer.
Well, I think those are great activities for cognitive engagement, but then I emphasize to them that there are really very few things that require as much as being in a social environment require. It is requiring multi-senses. So if you go into an environment and you meet someone or greet someone that you already know, you may be the sense of touching them, shaking their hand, or maybe even embracing them and giving them a hug, so you're really stimulating that sense. And then they may have a cologne or a perfume that you smell or that you recognize, and that may be stimulating your olfactory sense. And then it may also trigger some memories from your long-term memory or your episodic memory, things that are autobiographical. So you're engaged in a social aspect that allows you to trigger and be richly stimulating from all of your senses. So I really try to emphasize that. And I talk about, with my patients, the healing power of community. And I don't discount those games. It's just they're isolating, much like watching TV. It's wonderful to watch news or maybe watch a historical movie, but all day sitting and doing a passive activity such as watching TV, I strongly discourage it for all of my patients. So then we problem solve. What kind of activities might one be involved with that can keep you in a socially rich engagement? And so I recommend the support groups, certainly the Parkinson's support groups, and there are usually one in just about every community.
So what I got from that is that it's not appropriate to have, for date night to just be the movie. Okay, just want to make
There
sure.
you go. No,
All right.
not just that.
Okay,
Many other senses as well.
all right. So next question, this is for the docs. So can you review with us what the clinical criteria are for those people who might be eligible for DBS or deep brain stimulation?
So basically, we start thinking about deep brain stimulation earlier now in the disease course. And basically, it's when you start developing complications from the drug therapy, mainly levodopa, where you start having more wearing off symptoms where the drug is only lasting, it's not lasting the 6 hours it used to, now maybe 4 or 3 hours. And then you start developing uncontrollable movements or dyskinesias that are, interfering with lifestyle. Before we try to push it, we need to try this and this. But now the new clinical studies are showing that, considering early DBS may be better than, or is better as far as quality of life versus medication management. And so basically we think of DBS when complications start arising from the drug therapy.
And then, to add to that, Dr. Hadi, what can you counsel a patient on what to expect from their DBS?
So basically now I actually tell all our patients is that don't think of DBS as, oh, my disease is now really advanced and this is like a last ditch effort here. It is just like any other therapy for Parkinson's. And we use it in conjunction with the current medication regimen that we have. So we just have to optimize it. We have to continuously optimize the therapy to have the best quality of life. Basically, what we expect from DBS is the best response that we get from our medication. That's what I usually tell them. Okay, whatever you are getting with the medication, the response, expect the same thing with DBS, but the response usually lasts longer with DBS. And that's the kind of basic thing about DBS. And obviously that requires adjustment over time as well. So it helps us reduce medication load on our patients, which usually will have, as Dr. Thacker said, the side effects, the complications that we're getting. So we're able to reduce those complications and improving the quality of life, motor control with adding DBS.
And then Aaron, would you add to that about what people can expect from a walking and balance standpoint as it applies to DBS?
So for most of our patients, we're hoping that in the hospitals, whether it's the hospital therapist or the movement disorder neurologist, they're aware that these first few weeks after DBS are the most critical for balance and gait. So many of our patients, there is this thought that they have DBS and I'm better. And we have to educate them as physical therapists that it's going to take some time for you to adjust and for your stimulator to be turned on. So it's going to take some time to get the maximal benefits for gait and balance. So we really emphasize safety in those first few weeks, and it may even be months in terms of maybe still using the walker, using the cane, until we're appropriately adjusted and meds are now organized so that we can really get the most out of therapy.
Okay. So I kind of want to pose this the next question to all the panelists. A lot of times what is somewhat frustrating or challenging in the office is that patients come to you, it's their routine office visit, but there is some degree, in my mind, of preparation that needs to happen prior to the visit. Patients need to come, because you have a focused amount of time. So how would you counsel people on how to prepare for an office visit, whether it be with the movement disorder neurologist, the speech therapist, or the physical therapist, in order to best optimize the time that they have with you, and vice versa?
Usually we know all our patients nowadays are seeing multiple doctors. And, one doctor gives this, the other one gives a different medication. So the most basic thing I tell all our patients is to bring an up-to-date, make a list of their medications and bring that list with you. Because for me to rely on or any electronic system or chart is kind of unrealistic expectation, because that medication is in the chart never gets that much updated as somebody can have on their own list or with them. So that's our basic thing. And then usually it's a good idea to write down your concerns, questions, because it's hard for me to remember what to address in WASD, let alone somebody who has a condition, to know what they need to ask, to address all the concerns that they've had over the last few months. So it's always a good idea to write the questions down, write the concerns down, and then we can cover as much as possible during our visits.
Dr. Thacker?
So he basically said everything I was going to say, but even better, bring your bottles, because often, you bring the medications and we don't know the exact dosages. So especially in a new patient appointment, people are outside of our system. They're coming from, Reading or Stockton, and we don't know, what drugs are on exactly. So bring the bottles, and we can sort it out for you. And to put like a fine, exact schedule of when you take the medicines exactly, so we know kind of a good ballpark. And then, of course, whatever concerns, questions you have, write it on so nothing is missed during the appointment, because as we said, we're seeing a lot of patients, and so it's a short span, so we don't want to miss any issues that are kind of bothering you at that time.
And I have to say, oftentimes when patients don't bring their medication in with them, and they expect you would actually know what the color and the shape of that medication is. Oh, I'm taking that white pill. I have no idea. I try to make it look confident that I actually do know what they're talking about. Most of the time I have no idea what they're talking about. And the only time I really don't know what they're talking about is when they're on Cinemet, when it's yellow. So all forms of Cinemet for the immediate release are yellow in color. All right, next question. Well, actually, Aaron and Renee, do you guys also recommend that patients come to you somewhat pre-prepared?
Yeah, absolutely. It helps us in physical therapy, number one, to know what it is that your expectations are from therapy. We find that patients have sometimes absolutely no idea why they're in physical therapy. They think, well, my joints are fine. I don't know why I'm here. So it's important to kind of have a sense of what the patient's expectation is of us so that we can hone in that time and focus on everything that we need to. And the questions piece, of course, I think is great. Any questions, I love it when patients come with a list. It allows us to stay on track, and really, I want to give our patients the information they need on that first visit.
Sometimes in therapy, what we'll actually do is when I know a patient has an appointment with the MD, the neurologist, we will do some role playing where the patient can actually empower themselves to practice some of the questions that they might have. If they have an advocate in a family member or a friend, I encourage them to maybe even role play with that family member or friend just to have some preparedness before they go into that appointment. Sometimes that white coat syndrome sort of kicks in that you all wear.
Yes, that is true.
And for me, I send out a questionnaire ahead of time, and it has a lot of background information that I'm asking for on your developmental history and family history. What are the changes in your thinking that you've noticed, if any? And then to be prepared to complete that questionnaire and then bring it with you, along with somebody who knows you well, so that I can get an idea from them what they're observing in you as well, because sometimes with people who have changes in their thinking, the part of the brain that helps us be aware of difficulties that we're having can be affected, and so it's really helpful to have the input of a loved one or family member there as well.
Kimberly, when you give feedback to a patient and you tell them, they'd probably benefit from cognitive retraining, what is it that you say to them? And what type of advice would you give them?
So for somebody who I'm giving feedback to has some cognitive strengths and weaknesses, a lot of times I'll frame it that way, and I'll let them know kind of relative to your baseline before you developed cognitive decline related to Parkinson's disease. These are the strengths, that you had, and now we're seeing decline in these areas. It might be problem solving, it might be switching from one task to another, or multitasking. It might be learning new information and maybe just getting strategies to help with putting more information into the brain in a more organized manner so that you can get it out later when you need it. I would just recommend following up with their speech therapist and their neurologist or their primary care physician, I will let them know that I put a report in their medical record, and that was one of my recommendations for them. And they could also follow up with me as well if they have any questions in the future or run into any treatment barriers down the road.
And then if you are referring them back to the speech therapist, Renee, what is it that you would do with them? What is cognitive retraining?
So cognitive retraining starts with an evaluation of the cognitive abilities, and that can range from orientation to attention, concentration, the ability to complete two-step acts and to follow multi-step directions. And then also very much on a functional level, just wanting to know from a day-to-day aspect what the daily routine looks like. And what we'll find as the cognitive challenges continue to increase, and they do for some more rapidly than others, that initially we focus a great deal on therapy with retraining internal cueing. So it looks like you're actually viewing pictures and scenes and then trying to really sharpen and hone in on your visual memory abilities. So your short-term visual memory abilities and your working memory. Can you store that information that you've seen and or heard? And so we work on that, but we also always incorporate starting to utilize what are called external aids. And that is starting to have the patient and family members get comfortable with using reminders. And for the tech-savvy people, sometimes that includes recording with Siri. If they own a smartphone and know how to use a smartphone, I'm a strong proponent because it also practices your speech. Siri, remind me I have an appointment with Dr. Thacker at 9 o'clock. And so I love that component. I love the use of external aids. We all will need external aids at some point. So we start to actually do the training in therapy with external aids and with checkoff lists. Sometimes it might be as simple as to-do lists, and I'll find sometimes patients will say, but my writing, it's so tiny, and we'll state, of course, that's micrographia. So let's try to write the list really large, and if it comes to a point where you can't read your writing, maybe we can ask family member or your speech and language and cognitive therapist can maybe aid in that as well. But it's really about finding ways to continue to cognitively go over the hurdles and to make yourself be able to function as independently and safely as possible.
So then, Erin, do you do any kind of cognitive training with people?
So in PT, we try to do a lot of the dual tasking that we've heard about. So we're finding the most latest research is really supporting now that we challenge patients not only physically but cognitively and do it at the same time. So this is being done. One of our favorites is we may have people hold let's say a wall sit. So they're leaning into a wall, working their leg muscles, and we might be working on flashcards, simple math. Or one of our favorite evil things, it's one of our tests, and many of our patients hate this, but we ask them to count backwards. And we ask them to count backwards from maybe 100, maybe 50, but we have them do it in increments of 3. So they're having to do a motor task, and they're having to solve a problem. And it's fascinating when they see that they can improve in it too. So we definitely use this type of training as a way to show them that, in fact, they may have challenges when they are doing 2 things at once, because the perception is sometimes not there. They think, I can do this is no problem. And yet when we do the testing, we're finding that there is an issue. And then watching it improve as they engage in more exercise and put in the practice.
I would so fail that test. There are times where I'm asking patients to do it in the office, and I'm sitting there, is that answer right? All right. So next question. This is also for Dr. Hadi and Dr. Thacker. When you do decide and you guys agree upon the fact that, okay, we're going to start medical therapy, we're going to start prescribing medications, how do you choose between levodopa or maybe something else like an agonist or even one of the other medications such as a MAOI inhibitor?
So it basically, again, goes back to the nature of their symptoms. When we see, you see a variety of it. Some come in very early with very mild symptoms, and some patients are there who, haven't recognized their symptoms or didn't get referred. So they're a little advanced. So it depends on how much the symptoms are bothering them. It's basically how it interferes with their day-to-day functionality, how it affects their quality of life. So based on that, and we also have to keep in mind they're long-term course. We're not treating a person with Parkinson's for 1 day or 1 week. This is not a antibiotic course. We have to worry about 10, 15, 20 years down the line and make sure we optimize the medicines and minimize risk or complication risk from these medications. So usually if it's new onset, I usually start with the mildest of all the Parkinson's medications, such as MAOI inhibitors. And then based on the symptom that is bothering them, usually people who have a little bit more tremor, then I'll add something that has a little bit of dopaminergic effect or works through a different mechanism like amantadine to it as well, just to help with the tremor. So it depends on what is the actual symptom that's really bothersome, keeping in mind, if there's other side effects from those medicines that may contribute to their other symptoms, cognition and whatnot. So we have to look at a lot of factors before deciding on the medication.
Dr. Thacker?
When I choose the medications, I think one of the biggest factors, as Dr. Hadi said, is the degree of symptoms, but also the age of the patient, because patients that are above the age of 70 tend to have more side effects to the dopamine agonist, so I try to avoid that class of meds. Side effects like hallucinations, orthostatic hypotension, or dropping of your blood pressure when you're standing, confusion, and so that class we generally try to reserve for the younger patients, and we often will go right to levodopa because the older patients tend to have a lower incidence of the complications, specifically dyskinesias, where the younger patients, 50 years old, will have more of that. So we try to use the other medication. So age is probably the biggest factor when we're kind of deciding, and then the degree of symptoms and what symptom it is.
Okay, so next question is on somebody's diagnosed. Sometimes the worry is, what's the risk to my kids? How do you counsel patients on that?
Basically, that's a very common question that's asked. But so far, I think from what my understanding is the risk of Parkinson's, being transmitted into your kids is extremely low, unless there are multiple family members who are affected. So maybe that puts you at a little bit higher risk. But in general, the risk of Parkinson's going into your kids is pretty low. That's what I usually tell our patients.
I mean, for me, I always, so you have to understand that genetics, we always tend to think of genetics as what's called Mendelian inheritance pattern, that if somebody has the condition in one generation, that there is going to be a certain inheritance pattern to the next generation. Most conditions don't follow a typical Mendelian inheritance pattern. Most neurological conditions are polygenetic. What that means is that everybody here has a certain predisposition to developing Parkinson's, developing other neurological conditions. But multiple things have to happen for those biological processes to start to ultimately lead to the pathology of Parkinson's. So the likelihood of you having that same gene and then go through the same processes that led to your Parkinson's is pretty unlikely that that same process is going to happen to the children or to next of kin. So like Dr. Hadi said, I think that the probability is pretty low. Now that being said, actually there was a really nice study done by the Mayo Group almost 40 years ago looking at concordance rates between twins, identical twins with Parkinson's. If you develop, and of course identical twins have the same genetic profile, right? Exactly the same. So if you develop Parkinson's before the age of 50, there is a likelihood, can you shut that off, Dr. Hadi? Seriously, that's totally disrespectful.
It was I just wanted to, maybe some important information.
No, so this concordance rate is actually slightly higher in those people who develop Parkinson's before the age of 50, but actually not high at all. Actually, there's no difference with the general population if you develop Parkinson's after the age of 50, and this is in twins. So that's usually how I tend to counsel patients on that. Dr. Thacker, anything to add?
Yeah, definitely the age, again, is the biggest factor. Younger patients do have more, higher incidence of a genetic link. And as we said, there's a kind of an environment, a genetic association. You may have the gene defect, but if you're not exposed to the environmental toxin, let's say pesticides or head trauma, then the incidence would be potentially higher if you have that environmental genetic predisposition. So just because, you have multiple family members, maybe if you're not in that environmental situation, your risk is not higher. It quite depends, yeah.
So you brought up Pandora's box about the pesticides. We live in a highly agricultural area, right? Crop duster is going all over the place, right? What's our risk? How do you counsel patients on it? Should they shut off their intake when they're driving in the car? Should they actually only eat organic food? Should they only drink water from Avion?
So,
I'm not paid by Avion, by the way.
all the organic labels you see in Safeway or, Costco, and, all that is, thought to be good, and it's very trendy, but at this point, we're not making recommendations because we don't know. I mean, the definite risk is more people who, in their occupation, farmers who are exposed to it on a daily basis in, Central California. But as far as, pesticides transient through the window of your car or at home, we don't know for sure. But I eat organic just in case, but, we don't make this recommendation, because it hasn't been proven, yeah.
Do you really shop at Safeway and Costco?
My wife does. I just eat whatever she feeds me. And she buys organic.
That's what I thought. I can't imagine you in Costco.
No.
Dr. Hadi, what about the weed killers that we're using, that we're every weekend, we're cleaning up our backyard, and I'm right there. It's aerosolizing right in front of me.
It's the same thing. Basically, what you guys have alluded to is, not everybody who gets exposed to these things gets Parkinson's. Why not? So there has to be some other predisposition, some other factors that all comes together at the right time, and then we get symptoms of Parkinson's. So in general, nowadays, with the current pesticides and stuff, I don't say, okay, don't do this or that. Obviously, we need to be safe while we're doing that. But in general, I don't say specifically, avoid this or that.
So on the lines of possible pathology-genesis, what about head trauma? I have a lot of patients that go, well, could this be because I hit my head 35 years ago? How do you counsel patients on that?
So, distant past head trauma as you're younger, we all, have hits, playing sports and again, we don't know. There is some studies if you develop head trauma later in life, potentially there could be a link or higher risk of Parkinson's. And obviously these NFL players, where they're having head trauma on a daily basis, their risk is higher, as well as, CTE or dementia. But distant head trauma, it's a question mark. And maybe later in life, after the age of 55, there may be a higher incidence, but not, as a child, you fell out of your crib, could that cause Parkinson's when you're 60? That hasn't been linked, yeah.
Now, on that note, a lot of Parkinson patients are at risk of falling, right? Falling backwards, falling to the side, falling when festinating, getting stuck, freezing, and then falling. How does head trauma impact their Parkinson's? They already have Parkinson's, but does it change the course? Does it accelerate the course? Does it bring out new symptoms? So I'll start with you, Renee.
Well, many of the Parkinson's patients that I'm blessed to work with, unfortunately, have had histories of head traumas, and then some of them start to have the head traumas as a result of the Parkinson's and the increase of falls. And so we emphasize, many of our folks, what we do with on their walkers is we label the importance of the directions that they need to use, and again, we print it in big font about making sure that they have their brakes on. Just so cognitively, and we work often in conjunction with our physical therapists, so we work jointly so that we're labeling the information in the same manner in which they've heard it from their physical therapist, so that we can optimize safety and try to reduce falls. But we do have to incorporate that in our cognitive therapy because they are at high risk for falls, many of the individuals. So we incorporate that in, really, I know my patients so often, I'll say, much like being on the airplane, like the flight attendants will tell you, safety first. And so sometimes I will even write a sign in a neon color, and I will indicate that, safety first. And then we go through that training in therapy where we actually cognitively role-play scenarios and situations.
What if you don't listen to what the flight attendant has to say at the beginning
Yeah,
of the
that's a
flight?
problem. That's a
I never
problem.
listen to what they
I
have
think
to
we call
say.
that non-compliance.
Okay, all right, I just want to ask. Aaron, anything to add about what happens with head injury in Parkinson patients?
I think the kind of the hallmark has been spoken about, which is the safety. So we don't necessarily, we're not assessing that piece, but we are generally assuming that if there have been falls with head injuries or head strikes, we're assuming that there is a mild concussion or a mild traumatic brain injury. So using the signs and trying to always, above all else for us, we are trying to get our patients to avoid falls, always.
Okay. Sometimes a concern that patients have when they see us in clinic is, are we going to report them to the DMV and can I still drive? Dr. Thacker? Actually, why don't we start with Dr. Hadi?
So this is a very sensitive topic, and personally, the way I counsel our patients is, I'm not there with them when they're driving, and the person
You're not?
Usually not. So the person who's there with them is, their family member, their spouse, their close family members. So I usually say, first of all, you have to see if they feel comfortable sitting with you, because it's a matter of safety for themselves and for people around them. And if you have one, bad accident, that's all it takes, and you'll probably regret it for the rest of your life. So always listen to your family members. I haven't done it so far, ever reported anybody to DMV, and it's not legally you're not bound to do that for Parkinson's, but you still can. But I have never done that, and usually people understand this and they make their own decision, and most times it is the right decision. But motor-wise, when I start talking about this, I know that there is I see some signs on their examination, during their evaluation. So that's when I start bringing this topic up. Sometimes family members will bring it up, but that's how I usually approach this topic.
And then Aaron, are there any assessments that can be made in the therapy service to help people with their driving assessment?
Absolutely. So depending on your facility, some of the occupational therapists are trained in some testing to give you a better sense of what your ability is to make a decision, a quick decision particularly. In physical therapy, I mentioned the counting and walking test. We can often have a discussion based on the results. If we can see that from a motor perspective, as you're trying to problem solve, you're not able to keep up the same abilities, this becomes a big issue for us because we know that this is going to transfer to things like driving. Alternatively, if we look at the population in regards to age, we know that from the perspective of the cervical spine alone, particularly if we have a stooped posture, then I'm going to have a really poor ability to appropriately check my mirrors, to look before I'm backing up. So there are definitely things that we tend to see, and we'll try to have these discussions, but as you've heard, this is a very sensitive topic for many people. So for our group of neuro-PTs, we will recommend sometimes AAA, or AARP has a driver's assessment. And I know that DMV, I think, is here today with some information about how to be tested if there's any doubt. Because again, if we keep that safety first, that's what we're always recommending to our patients.
And I don't think DMV is here to collect your guys' names in order to report it, okay? Like Dr. Hadi said, it's a reportable thing to DMV, but not mandatory to report on, the way that epilepsy is or maybe dementia can be. We're good with
Dr.
time,
Kandar?
Nancy?
Can I add something?
Please, yes.
So actually, 2 years ago, when I served on the panel, Lula Cappuccino is an occupational therapist who came and shared her information with me 2 years ago at this conference. And I have since referred many patients there, and she's an occupational therapist who has the vehicle. And so she will first do some testing in a written format, and she will decide whether or not she feels, based on that assessment, if the individual's safe to even be in the vehicle. And if they do pass that portion, then she will actually do a driving practical test with them. And I've had patients that have had favorable outcomes where they have reclaimed driving again. What it does is it offers a lot of self-confidence for the individual, and then also for family members. So to have that, and so I will encourage family members, why don't you go ahead and have them evaluated, and that way you can just determine the safety.
That's a very good point, thank you. All right, well, oftentimes patients will come into the clinic and sometimes, their concern is not so much the motor symptoms, but the non-motor symptoms. One very common non-motor symptom in Parkinson's is constipation. And I was told by a mentor where I did my training that after the age of 50, the most important part of your day is whether you had a good bowel movement that day or not. It seems to ring true with a lot of my patients. So how do we help patients have more regular bowel movements? Dr. Thacker, I'm going to give this to you.
So constipation basically can be one of the earliest signs of Parkinson's. It actually can predate the symptoms, the motor symptoms in a lot of patients. So some people believe Parkinson's, may start all in the gut. And so these symptoms are very difficult to deal with because, we don't want to get in the habit of taking laxatives, on a daily basis because that kind of just exacerbates the whole issue. And so it all kind of starts with diet. I mean, increasing your fiber intake, some fruits and vegetables, avoiding, saturated fats, low simple sugars. Lots of water, fluid helps everything, it helps your blood pressure, it helps maintain bowel movements. If you do need to take something, Miralax is a good something to do. It's over the counter. Basically, it drives all the fluid into your gut and keeps things moving. And so that's something that's safer than your typical laxatives. And then lastly, the answer to every question is exercise. Exercise helps, again, everything, and that can help stimulate you. So I have no problems with bowel movements. I exercise every day, drink lots of fluids. It's just the key to life, I think, yeah. Unlike Saketa here, he's just sitting on the couch and
That's true.
drinking beer. Wine.
But no, I did go on that raft at Disneyland.
Oh, yeah, the Disney raft.
Just,
And he's the one who likes Taylor Swift, not me.
listen, I'm not the one on the panel right now, okay? Okay? What he's referring to is I drive a red Prius, and my daughter refers to my car as Taylor because the red looks like the lipstick of Taylor Swift. And I can't shake that name. I'm trying to call it Daredevil or Superman. It's Taylor, and everyone knows it, and I can't win. All right, so that being said, you mentioned diet. And oftentimes I get asked about diet and Parkinson's. Is there a Parkinson diet? Is there something that patients should be doing, eating? I'm going to give this to Aaron because I know this is dear to your heart.
I can get in a lot of trouble with this question. And we know that this is actually very controversial. We don't see a panel of experts that will agree upon nutrition for Parkinson's very often. A couple caveats that I will say I think most, whether it's dietitians or physicians, will agree upon is that limitation of dairy products is beneficial. We know that dairy tends to be slightly irritable to the bowel, so when we talk about constipation, we can improve that if we limit our dairy intake. Most recommendations you'll see is the size of your palm, so about 4 ounces for dairy. I cannot emphasize the water intake enough. We ask patients sometimes to track water, and we find some are drinking less than 20 ounces of water a day. So you can imagine that's just not enough to sustain or to have healthy bowels. So I think the dairy piece is one that I speak the most to my patients about. There's a lot of information about whether you should eat meat or no meat. I will say in general, I think the Mediterranean diet has been agreed upon by most as one of the best options, whether it's Parkinson's or other neurologic conditions. So I'll leave it at that, but I would say for sure water. If you do nothing else, increasing your water intake, particularly if you're exercising, right? If we are exercising, you need to have that extra water intake.
So not the McDonald's diet, the Mediterranean diet.
Correct.
Okay.
Yeah.
All right. Anything to add, anyone else on the panel, when it comes to diet? How do you counsel patients? Because I would imagine that patients probably come to each and every one of you asking about diet.
A related question, you get asked a lot about should every time you take a medication, should it be taken with food or without food? And if it's going to, affect their symptoms in any way. Personally, the way I address it is, initially when people are, taking medication, it's a complicated, schedule. Every day you have to remember to take it 2, 3, 4, whatever number of times. And then, having to schedule it according to your meals, it takes a lot of time and effort. So usually what I will tell patients is that initially, if they have a good response from their medication and they continue to have that consistent response throughout the day, I usually don't make them, take the medicine separate from their meals. It's when they start having issues with medications, when they say, when I take it, sometimes I don't even feel that it works, sometimes it doesn't last long, sometimes it lasts long. and when I take it with food, I don't see any benefit, that's when I usually start saying, okay, why don't you try it, before meals, or give it a little bit gap between the meals and the last and medication, and to see if it's affecting absorption of the dopaminergic medication. So I just try to keep it simple initially, because they have a lot of things to think about anyway. So I start with keeping things simple, and then later on maybe.
I mean, I would agree. I wouldn't say that I try to have patients take it separate from food. But when they first start out, when they're first starting their medications, particularly the levodopa, I'll have them take it 3 times a day. And compliance-wise, it's a lot easier with breakfast, lunch, and dinner. And if there's nausea that comes from it, it's a little bit easier, because at least until their body adjusts to it, it's better. But once it adjusts, it's almost better to take that medication 30 minutes prior to a meal. I think for me at least, if that medication is going to be absorbed in about 20, 30 minutes, it's absorbed in the second part of the small intestine. So once that happens, it doesn't really matter what you eat afterwards. And I think it's a lot easier to remember to take the med first and then 30 minutes later have the meal, as opposed to the other way around. Heavy protein takes a long time to be absorbed. So if you actually have a heavy meal and then take your med, you got to wait a couple of hours until that med can be truly absorbed. Dr. Thacker?
Yeah, I definitely think the protein is an issue, and patients, as they advance, the protein, they could be even more sensitive, and especially if they're on longer-acting drugs of the Sinemet. So some patients, I'll have them do all their protein at night, and so during the day, they kind of have like more of a high-carb type of meal, and then that way, they're not having so much interference. Because if you're taking the drugs every 3 hours, it's impossible to kind of, take your protein. I mean, you have to eat it within a minute, and then you have to, go on. It's just impossible. So that's kind of a strategy as the disease progresses.
And then, Aaron, you had mentioned a little bit about meat. And is there any kind of meat that might be better than other types of meat?
So I think boy, this is a tricky one. You know how to push my buttons. The only study that I'm aware of currently would be some potential contamination in certain fish. So we know that, for instance, tuna has a high mercury content, and that starts to get into an area that I'm not an expert in. But I'll just say as well, I know I've heard some of the experts about nutrition for Parkinson's mention staying away from pork as well. So I've certainly heard that fish that are higher known contaminant fish and then pork are meant to stay away from for the most part. Again, none of this is confirmed, so it's that same situation where whether organic or not, there's many recommendations that we just don't have the science to really get 100% behind.
Do you guys give any recommendations, Dr. Hadi?
No, food-wise, whatever you like to eat, but there are only a lot of other restrictions. I don't want to make it too. But when you hear things, okay, people say, well, when I do this or eat that makes a difference for me. Yeah, it's very individualized. I mean, it's hard for me to, like a blanket statement as far as these. So it's very individualized.
And sometimes I'll actually counsel patients that if you're going to have meat, it's best to avoid the red meat, some of the contaminated fish, and if you're going to have something, it may be the white meats or more safer fish. But there are also other forms of protein. They don't necessarily, both, Erin and I are vegetarian, and so.
Vegan.
Vegan, sorry, she's vegan.
There's a
Yeah, I like my pizza. Anyways, any recommendations, Renee, do you give to patients? Because sometimes swallowing is an issue in Parkinson's, so how does that factor in?
Well, we emphasize the importance of safety first. So when it comes to swallowing, oftentimes people have difficulty with some of those foods that you're just describing. One of the most difficult things most of my Parkinson's individuals say they have difficulty with is chewing either chicken or beef. And so I recommend that if they have that, they have a very small portion of it and that it be diced and good quality.
All this talk about food is making me a little bit hungry,
Yeah.
so I know that we're actually close to lunch break over here. So this was the first hour of our panel. You guys now have a little bit of appreciation as to some of the complexity of these issues that can plague you, but also the challenges that we face in the office of how to respond. Hopefully you guys have asked some questions on those note cards. We'll be collecting those note cards and then reviewing them for us to be able to ask during the second hour of the panel. But I think for now, we're actually taking a break, right? For lunch. Thank you. All right.